Thank you, Dr. Kim, Jason, and Tom for the invitation. Today, I will show you clinical examples and illustrations of why surgeons should not take electrosurgical energy devices for granted. We all still call it electrocautery. That's old-fashioned, and it's physically wrong, and more importantly, it implies a non-threatening device. Sure, most of us feel completely at ease with it, but the reality is far from it. Very few surgeons can explain the function of these devices, and fewer even the potential threat that they represent for surgeons and patients. I have nothing to disclose. At the end of this presentation, I hope you will agree that electrosurgical complications are dangerous because they are rarely detected at the time of injury. They occur much more frequently as suspected. They are not easily understood, and they can carry a significant delay in diagnosis because they are too often dismissed as something else. Again, electrosurgery is not cautery. Cautery is the passive transfer of heat to tissue. And yes, surgeons have used it for thousands of years. Electrosurgery, on the other hand, is only 100 years old. It provides surgeons with a larger variety of tissue effects, and therefore, the revolutions in surgery in the last 100 years, especially the laparoscopic revolution, could happen. But as with cautery and fire, there are still sparks. Those sparks can ignite fires. This young woman had elective surgery for a benign facial lesion. She has allowed the media to display her case. As you can see, a lifelong, devastating outcome that was basically completely preventable. If only the surgeon had understood that electrosurgical devices can create sparks, that there are certain settings where the risk of the fire is very high, and that there are easy steps to prevent this. The most difficult thing to understand is how electrosurgical burns can happen out of nowhere. The main reason is illustrated here shortly in the video, and it is that the electrical current going through your laparoscopic instrument produces an electromagnetic field. That field can transfer energy from one instrument to another without you knowing it. That's why so often one cannot anticipate or see the injury happening. The surgeon has to understand this concept if he wants to prevent inadvertent burn. This is especially true with the long laparoscopic instruments, as shown here. They act like large antennas, perfect receivers and perfect emitters of energy through the electromagnetic field in your operating field. And this video will illustrate this. So here you have a long laparoscopic instrument, and you can see how the energy through the insulation is transferred to the tissue outside of the active area of the electrode. And this happens even through tissues that's wrapped around this electrode, as you can see here. So just imagine this is bowel wrapped around your laparoscopic instrument or your cannula. The simplest situation in the operating room where electromagnetic field effects come into play is when an electrical cord is wrapped around an instrument. I still do this on occasion. It's such an ingrained practice, but it's dangerous. Both the surgeon and the patient can sustain burns. As you can see here, the instrument becomes electrically charged and can create tissue effects like burns in this case. Although the instrument itself is not connected to any direct electrical contact, it's the electromagnetic field created by the cord that transfers the energy from the activated monopolar instrument. This, on the other hand, is a clinical case where the outcome is much worse. A colon perforation occurred during a laparoscopic prostatectomy from an inadvertent burn, and the patient survived after 7 operations, as seen here on the right. Sure, these injuries are rare, but there are so many cases done that it adds up. You do the math. Here's another devastating injury. I'll give you 5 seconds to guess for yourself what happened. The burn is from an electrode, a return electrode. We don't call it a grounding pad, although many still do. Nothing is being grounded in electrosurgery anymore. It's part of the electrical circuit. Therefore, this is charged with energy, and it's delivered through the electrode and can lead to deep burns if the electrode or the returning pad is not placed correctly. In a poll done at SAGES, 1 in 10 surgeons thought that it is okay to cut a return electrode to size. That's the outcome you get doing that. This is another case. This is a stomach from a youngster that died from gastric full-thickness burns and leaks. The surgeon used a ligature device for Nissen. Because of large amount of fat, visualization during surgery was very limited, as stated in the up note. Post-operatively, the patient complained for 10 days about abdominal pain. He was seen in follow-up, but sent back home. And he died from profound septic shock one morning, unable to be resuscitated. This is a portion of the small bowel of a patient that was taken back for postoperative intestinal perforation. This is not the portion that was perforated. This is another portion, not involved in the perforation. What you see here are 2 serosal burns. They are not full thickness. Electrosurgical burns do not necessarily lead to perforation. Probably more often than not, this occurs, a serosal burn. Just think of it when the patient returns to the emergency room within a week of laparoscopic surgery for quote unquote abdominal pain. It's like the pain syndrome after endoscopic polypectomy, only from the other side. Electrosurgical instruments can burn both the patient and the surgeon when the insulation is faulty. On the left, this is a video showing that gloves are not perfect insulators. All of you have experienced burns because of that. You can see that the energy, you go back here, you can see that the energy is transmitted through the instrument and then causes a burn of the instrument holder. This video shows that even new instruments, when unwrapped for the first time, can have insulation failures. You rerun the whole thing. This is an instrument that was freshly unwrapped for a demonstration, and then the holder was burned, and then we demonstrated that there is an insulation burn. Up to 30% of these instruments can have insulation failure right out of the wrapper. For those of you that do single-site surgery, this video demonstrates why it's the perfect storm for electrosurgical injury. First, the proximity and the parallel configuration of the instruments, as you can see here in the video, facilitates greatly the transfer of electromagnetic energy from one instrument to the other. Second, when you look here on the picture out of this video that I've magnified, you can see that one of the instruments, the active instrument, actually has an insulation failure. I don't think that the makers of this video were actually aware of that. And it was hard to pick up. And if you had been the surgeon, would you have seen it? Probably not. Then there is the situation where you have an implantable device and you're operating in the vicinity with an electrosurgical instrument. This can happen. Now you can see there on the bottom, the instrument is activated, and what happens and what is shown here is that the tip of the lead from the implantable device, where the energy is most dense, heats up. Even though you don't see the burn happening with the naked eye necessarily, that lead gets very hot because of transferred energy through the device into the lead. And now you can see how that lead created a burn. Clearly, in a situation like that, the device becomes non-functional and has to be replaced. Making surgeons aware of the problem and the potential for burns helps a lot. And so the French Surgical Association established a nationwide voluntary database for energy devices and their related injuries. Within 1 year, over 600 injuries were self-reported, most of them electrosurgical burns. Almost all surgeons reported having witnessed injuries to the surgical the patient from surgical energy devices. There's now a lot of teaching going on in France about this. Let me just describe quickly 3 cases. Here's case number 1. 41-year-old woman, healthy, has cholelithiasis, no cholecystitis, underwent elective laparoscopic cholecystectomy, and a monopolar hook was used. 10 days after surgery, she was readmitted with biliary peritonitis. She was immediately taken for relaparoscopy and found to have a puncture hole in the common bile duct within the dissection field in Callot's triangle. That was repaired and she recovered uneventfully. And clearly the conclusion was that this puncture burn of the common bile duct had to be due to arcing from the monopolar hook or direct inadvertent touching. The second case is a 70-year-old woman with cholangitis on plavix. She underwent emergent laparoscopic cholecystectomy with common bile duct exploration. She had interoperative hemorrhage, which was controlled with electrosurgical monopolar hook. 6 days later, readmitted with biliary peritonitis. The findings showed extensive necrosis of the hepatic duct and the proximal right hepatic duct, which prompted a reconstruction of the biliary ducts through MRI anastomosis. And the conclusion here was that the necrosis was due to electrosurgical technique, probably during the hemorrhage, inadvertent injury to the common bile duct in an attempt to control the hemorrhage was done. And an early conversion to open surgery might have prevented this complication. The third case is a 37-year-old woman, healthy, same day uneventful laparoscopic cholecystectomy for gallstones, readmission to the ER 1 week post-op for abdominal pain. MRI was done, perihepatic fluid was seen, but unfortunately there was just the first-year resident in charge. He called the attending and they both agreed that the MRI thought to be within normal limits of early postoperative findings, and the patient was discharged home with pain medication. 1 week later, the patient passes out at home after continued abdominal pain, and even though resuscitation was done, the patient expires. At autopsy, a large amount of succus entericus is found in the abdominal cavity, but the intestinal perforation is not found by the pathologist. Clearly, enteric full-thickness burns from electrosurgical devices are very small, so it is very, very likely that this was an electrosurgical burn that was unrecognized intra and post-operatively. Dr. Cassano did a study reviewing the published literature on laparoscopic bowel injury incidence and mortality. And he found that the overall incidence is 1%, of which 1/3 are unrecognized at the time they happen. The overall mortality was quoted at 3%. The mortality of the unrecognized cases at 8%. A full 1/3 of these cases were due to electrosurgical instruments. And it is estimated that per year in the US, 40,000 patients sustain burns related to electrosurgical devices. So, I hope I have convinced you of what I said in the beginning. Complications from electrosurgery are rarely detected by the surgeon and are more frequent than you think. They're difficult to understand unless you recognize how electrosurgery works. The outcomes are often delayed, which makes it easier to dismiss the symptoms as unrelated. SAGES is offering a free online curriculum on the use of surgical energy devices called FUSE, and I strongly urge you to take that curriculum and learn about these devices. With that, I thank you for your attention. If you have any questions, please email me.